Hello, and welcome to the Postpartum Years podcast. I am your host, Dr. Mary Ellen Kramp. I am a physical therapist and a pelvic floor specialist. With me today is my buddy, Catherine Halek. She is an internationally board certified lactation consultant extraordinaire. And today we're going to be talking about undersupply or low milk supply. So, Kat, the first thing I'm going to want to ask is explain low milk supply.
So I think it's helpful to know that low milk supply is simply not having enough supply for a baby to adequately gain weight.
That's pretty self-explanatory now, isn't it?
Yeah. But in the research, you see all kinds of numbers, all sorts of things, and there isn't a clear consensus about what it should be. And there's a difference between like direct breastfeeding and how much milk are these babies getting when they're direct feeding versus when we're exclusively pumping, and how much babies need to gain weight adequately when we are taking the milk out and not direct feeding and instead bottle feeding. So when we did research about it for the Nourish Project, I had a hard time finding a clear answer of what is low milk supply, to be honest.
Yes, I did read those articles as well, and it was different numbers in each article. So I can see how that might be confusing for a lot of people.
Yeah.
So what are the causes of low milk supply?
So low milk supply has lots of different causes. One of the biggest ones, I would say, is not having adequate stimulation and milk removal in the first 3 to 5 days after giving birth. That's a huge one that I see, and I'm currently working in a hospital, and I'm constantly trying to educate these moms. They're like, I want to do both breastfeeding and formula feeding. And I'm like, cool. But if you want to have breast milk, stimulating your breasts now, really important. And these are moms that, just had a massive C-section and are exhausted or had a traumatic birth. And it's just really hard for their brain to go like, this is important over me sleeping or over me, resting and being comfortable. But that's a huge sign. Like, that's a huge precursor to low milk supply.
Okay, so let's dive into that just a little bit on how actually the milk supply is developed in those first few days.
Yep. So milk supply, your glandular tissue starts producing colostrum while you're in about the second trimester of pregnancy. And some people leak and some people don't leak. Both are normal. Okay? So it's not necessarily a sign that things are going good or bad if you're not leaking during pregnancy. The baby's delivered. The placenta is delivered. The receptor sites are plugged in with progesterone during pregnancy when the placenta is developed. When the baby is delivered and the placenta is delivered, the progesterone leaves the receptor sites, and every time that you have nipple stimulation or milk removal, then prolactin goes into those receptor sites, and prolactin is the hormone that makes milk. So if you don't have the nipple stimulation and the milk removal, those receptor sites will just close up and not to be opened up again until the next pregnancy or maybe ever. So that's why that nipple stimulation in the very first few days is key for establishing the foundation for milk supply.
Okay. And so riding that wave of progesterone.
Yes.
I am familiar with one of the causes of low milk supply is the retained placenta.
Yes.
And that is partially due to the placenta is producing progesterone.
Yes.
So if that is not fully expelled,
Yep.
then that progesterone is still preventing prolactin from getting into those receptor sites. So that is one cause of low milk supply.
And what's really interesting to me is that previously to working in the hospital, I saw one case of retained placental fragment that affected somebody's milk supply. And now that I'm in these women's charts and I'm reading like how their delivery was, or did they hemorrhage, or did they need to have like tissue removed, I'm seeing more and more that it actually might be happening, and we might not be like picking up on it because it's like even a tiny amount of the placenta being left in the body can trigger a retained placental fragment and low milk supply, which is crazy to me. So it's like reading the charts of like the births and like them having to like basically clean people out, super medical term there, after the placenta out of these women's uteruses. I'm just shocked that I'm seeing more mention of retained placental fragment. And I was like, wait a second, I thought this was super duper rare, but now I'm in these charts and they're like, yeah, it suspects, possible retained placental fragment going back in to clean it out. And I'm like, well, I didn't know that was happening. And I also think that because people are breastfeeding more and doctors are more aware of it too.
So let's also talk about mode of delivery.
Yes.
Because that can impact.
Oh my goodness. If you get a bunch of lactation consultants in a room and we start talking about like, chicken or the egg, like does C-sections cause, low milk supply, or do C-sections cause a delay in onset of lactogenesis 2, which is basically when the colostrum goes from orange. So your milk starts off, I call colostrum orange juice concentrate. Okay. And not everybody gets this reference anymore because I think there's not a lot of people that are making juice from orange juice concentrate anymore. And I'm kind of sad about that because that was like a pivotal part of my childhood, is going into the freezer to make juice, And so for those that don't know, because there's going to be people listening to this that have no clue what orange juice concentrate even is, back in the day, you had a frozen can of orange juice concentrate. You'd open up the can, you'd pour it into the jug. You would add however many cans of water that the orange juice concentrate container said, usually 3. If you wanted extra sweet, you added 2. If you wanted a little watered down, you added 4.
If you had 8 brothers and sisters, you added 5.
To make it stretch. So you had a whisper of orange flavor, right? So the body, colostrum, I call that orange juice concentrate. And then lactogenesis stage 2 is when gradually somebody's pouring water and more fluid and the milk changes into more volume, okay? And that's often what people say when the milk comes in. So, and milk comes in for most people between days 3 to day 5. But in the case of C-sections, it's often delayed up to 7 to 10 days. And so, like I said, if you get a bunch of lactation consultants in the room, we're going to talk about is it the actual act of being cut open and having the baby not born vaginally? Is it because the mom didn't labor, or did the mom labor and then had an emergency C-section? Is it the postpartum blood loss that's affecting the milk, chicken or egg? It affects it. It affects it. We can't get around it. Speaking from personal experience, my milk was delayed a whole week from coming in. And I was not aware. I was not aware that that was a consequence, a risk, or that was happening. But also, I wasn't feeding my baby frequently enough because I was recovering and I was exhausted and I was on pain meds. So it's like, was it the method of birth that caused it? Or was it how you recover when you have a C-section that causes you not to have that frequent nipple stimulation and milk removal adequately? Chicken egg. Yeah. So we still don't, there's a lot that we still don't know.
Yeah.
Yeah. So C-sections or medicalized births in general can, like inductions, like when the body doesn't naturally do what the body is supposed to do, it can cause more challenges with milk supply. It can cause more challenges with breastfeeding. And that's not to say, like, I breastfed a child till 2 with a C-section. So you can overcome challenges. And it's not to say that if you choose to have a C-section or if you choose to have an induction that you can't produce milk. Everybody's journey is their own.
Okay, so along the same vein of medicalized births, hemorrhage
Yes.
is a significant factor
Yes.
for some of us.
Yes.
Between the hemorrhage, low blood pressure, end up with Sheehan syndrome in some people. Would you like to touch on that?
So Sheehan syndrome is basically where there is a significant amount of blood loss during birth, about over a liter, 1,000 milliliters. And what that can do, that rapid loss of blood, that postpartum hemorrhage, can cause damage to the pituitary gland. And the pituitary gland is the kind of like the ringleader of the prolactin, the progesterone, and oxytocin?
Oxytocin's posterior pituitary. Anterior pituitary is going to be prolactin.
Okay, so it must be the damage of the anterior pituitary. Also, you guys, anterior means like towards the front or the center of the body. Posterior means towards the back or the middle of the body for people that aren't anatomy and physiology nerds.
Yes. Okay, so the lack of blood, lack of oxygen to that anterior pituitary will then kind of nix the body's ability to release prolactin.
Yes, and then if the body is not releasing prolactin, what's not getting filled? Those receptor sites. If those receptor sites aren't getting filled, they close up.
Right, and milk is not being produced.
And then milk's not going to get made. We're not going to transition from colostrum to stage 2 milk or transitional milk, where your milk comes in.
So let's talk about a couple other issues. Insufficient glandular tissue
Yes.
with low milk supply or no milk supply.
Yeah. So insufficient glandular tissue is where during usually puberty, the breasts did not develop fully. And then in some pregnancies, due to hormonal issues, the breasts don't develop in pregnancy either. So you can have it from adolescence, where maybe you were overweight, you had insulin resistance that you were struggling with, and you didn't even know it as like a teenager, as your breasts are developing, and they never get enough glandular tissue to be able to bring on a full milk supply. Or during pregnancy, not having the right hormonal mixes or insulin resistance, again, can also impact breast changes and breast development during pregnancy, where the glandular tissue does not grow and multiply. So a question that everybody should be asking themselves, or should be asking a new mom, when, like, did your breast change during pregnancy? That's like one of our main questions. Like, how did your breast change during pregnancy? Here's the thing, though. Sometimes women will say no. And if their partner is in the room, I ask the partner, hey, did her breast change during pregnancy? And I trust their answer more than the parent, the mom. So, because, the partner is usually paying a little bit more attention to the woman's breasts than the actual woman is. So, just saying. And yeah, and it also kind of breaks the ice and is like a little joke. So it kind of helps, because what I do for a living is very intimate, and sometimes it's a little nerve-wracking to talk about those things. And so when I ask the partner and the mom laugh, a little ice has been broken.
So what types of problems did those women tend to have?
They simply don't ever make enough milk. Their milk will transition from colostrum to a fuller, more liquidy milk, but it may not ever be enough to support what the baby needs to be able to grow and develop. And a lot of women that have insufficient glandular tissue blame themselves for lactation failing. A lot of people with low milk supply in general blame themselves. I had a really wonderful moment with it was like my second day working in this hospital. I've been a community lactation consultant for so long, and I'm talking to this woman, and she's telling me the story of her first lactation experience and how hard it was and how she struggled to have enough milk. And she opens her gown up, and I look at her breasts, and I'm like, oh. And this is after a boob job, the boobs look like this? Oh. And I knew from some of the things she was saying in her history, and I asked for like a before picture of her breasts if she had it, and she did. And I saw it. And I looked at it, and I was like, oh, you have like telltale signs of insufficient glandular tissue, and you've had an experience where you've never been able to produce enough milk. So it's like I like both have to be there, okay? I wouldn't have made a big deal about what her breasts looked like if she hadn't already experienced that, because you never know. Some breasts surprise me, and they look funky, and they look like they might have glandular tissue, and they produce plenty of milk, and I'm like, I don't understand. And so I don't like to plant that seed, especially for first-time moms. But for this mom, I sat down and I just said, hey, I don't know if anybody's ever told you this, but you have all of the signs of insufficient glandular tissue. And she's like, what? And I explained to her, you don't have enough tissue to make milk. So no matter how hard you work to make enough milk, it ain't happening. And I was like, it might be better with this one because pregnancy, so glandular tissue develops in puberty, glandular tissue develops with menstruation, glandular tissue, that's why your boobs hurt when you're, PMSing or around your period. And glandular tissue develops during pregnancy. So sometimes somebody with insufficient glandular tissue might have more success with lactating with subsequent births, okay? And I told her that, and her husband started crying. They're like, it all makes sense now. It's not our fault. We didn't do anything wrong. And I'm like, no, your body just, for whatever reason, wasn't able to produce enough milk. And I got goosebumps. They were so appreciative that I said something. And the funny thing is, 2 other lactation consultants had seen them and had written a note that was a suspicion, but hadn't said anything to them. And I was so happy that I felt comfortable telling them that. And they were like, so, we can give it a try, but maybe we can cut ourselves some slack if it doesn't work out sooner and not beat ourselves up thinking that we've done a whole bunch of things wrong. And I'm like, yes. And let's set you up for pumping and breastfeeding so that we can give, as much stimulation to whatever glandular tissue does exist so that you have as much of a chance for success as possible. Yeah.
And it doesn't matter the size of the breasts.
Nope.
So you could have rather large breasts and still have insufficient glandular tissue.
Yes.
Because it's composed of both those glands and fat.
Yep. And it's really important to not judge your, if you're pregnant right now and you're Googling insufficient glandular tissue and you look at pictures, your boobs might just be fine. I've seen some breasts that I was sure were going to have IGT issues have a full milk supply. And sometimes women with less glandular tissue, they do, however, need to stimulate it more frequently. So I worked with one dyad where the mom, if she didn't breastfeed or pump 14 times a day, she didn't make enough milk. But if she breastfed or pumped 14 times a day, she did. That mom breastfed for about 3 months and then decided that was too much when she returned to work and needed sleep. But she was really happy that she was able to, with my guidance, figure out okay, I could do it, but this is what it would take.
Yes. It's really rough psychologically for a lot of these women because, again, they feel like they've failed their baby. They feel like their bodies have failed them.
Yes.
So it's a rough go for them, just trying and trying and trying at a time when they're exhausted, at a time where their body's trying to heal, at a time where they're trying to get to know this brand new little human being that they need to care for 24/7.
Yeah. There's a lot of guilt and shame or people don't understand, and oftentimes doctors don't understand. I will have developed a very careful feeding plan and pumping plan for a dyad, and then they go to the pediatrician and they're like, why are you doing all that work? You should just breastfeed more. And I'm like, if they could, they would be doing it. But they are having issues. And that's why don't screw with my plan. We finally got things better. You don't know what you don't know. And it's usually coming from pediatricians because the mom isn't their patient. And so it's not going to be common for a mom to take down her bra and be like, hey, look at my busted nipples. I'm doing the best I can. You know what I mean? Or, hey, look at my breast. I have insufficient glandular tissue. I have to supplement with formula. And it's also just a really personal journey and experience. And it's like, it's not other people's business. When I work with clients, I often am the type of lactation consultant that at some point will be like, what are we doing here? I understand how important this is to you, but the amount of work that we've invested in this, for the amount of progress that we've made, it doesn't math. It doesn't make sense. Mm-hmm. And you might be happier, and the better decision, instead of continuing to struggle and driving yourself into postpartum depression and anxiety, would be the better gift for your baby than more suffering to get drops of breast milk, would be for you to let it go and be a more present and available parent. And so I've had that conversation with a lot of my low milk supply dyads. And unfortunately, people don't have those conversations. And I like to say that part of my job is giving people permission. Mm-hmm. I give you permission to stop for your mental health, mm-hmm. because your mental health is more important than your milk. Mm-hmm. It just is.
You'll be a better mom.
Yes.
If you're not that stressed.
Yes. And also, guess what? Stress about low milk supply causes low milk supply. Ain't that fun?
Let's stay in this loop. One thing you had mentioned with that first mom with insufficient glandular tissue was she had implants.
Yes.
So let's talk about how breast surgeries will impact.
Yes. So breast reductions can impact lactation, because sometimes they actually do remove glandular tissue, and not just fat. And also how breast surgeries are done, sometimes nerves are damaged. The third and fourth...
thoracic nerves.
Yes, thank you. Thoracic nerves is what innervates the breast. And if there's like a damage to those nerves on the pathway to the nipple and the breast, then sometimes breasts don't work. Also, sometimes for different surgeries, they will remove the areola or they'll detach it significantly. And the areola and the glandular tissue right underneath the areola is very key and critical. Or they'll move the nipple and areola to where...
a higher position usually?
Yep, for breast lifts. Implants, I find that a lot of people can successfully lactate with implants, but they do wind up having a higher chance of having like plugged ducts and mastitis, engorgement, chronic engorgement, because the breast is basically just like, the implant is basically just pushing the breast tissue forward, and that's just causing everything to just be tighter and compressed. So I would say that people that have breast implants can breastfeed, and I've supported so many dyads that have had them, but typically I see a higher incidence of challenges.
And let's talk a little bit about some of the other more hormonal things, like diabetes and thyroid and PCOS, and how that impacts milk supply.
I'm on a mission to educate people about insulin resistance, because what happens is pregnancy, a lot of times people are ignoring their bodies. They're not paying attention to themselves. Then they get pregnant. Then they're in like regular care with a doctor. And a lot of health issues come up that they never knew or weren't paying attention to or were ignoring or avoiding. And insulin resistance is one of those things. During pregnancy, there is a gestational diabetes happens, and doctors are telling moms after they delivered, oh, you had your gestational diabetes controlled during pregnancy through diet. Cool. The second that baby pops out, go get yourself a candy bar. Like, have at it. Go eat all of the processed white carbs that you want because you've been abstaining your whole pregnancy, and it will be fine. And it's often not fine because the insulin resistance can continue to cause an issue with the milk supply. And so now that I'm in the hospital, I'm like, so I saw that you have gestational diabetes and you want to breastfeed. How have you been managing it? Oh, through diet. Oh, I see that donut you're eating. Okay, let me give you some bad news. Let me tell you what nobody's telling you, because they don't know. And I like doctors really, they don't know a lot about breastfeeding and breast milk unless they've taken it upon themselves to study extensively. And so when they're giving this advice, they're like, everybody, I want to tell people to eat a cookie. I want to tell people to eat what they want and enjoy life, right? I don't want to make people abstain from something that's enjoyable. But at the same time, if that mom really has the priority of breastfeeding, we're doing her a disservice by saying, yeah, you can eat what you want now. Don't worry about it. Also, having gestational diabetes puts you at an increased risk for type 2 diabetes. And guess what helps you reduce your risk of having type 2 diabetes? If you breastfeed. So it's better for this mom's health long term. So that's kind of how I often explain to people, like, if you continue to eat a diabetic diet, you probably will feel healthier and do better. So it's not just for the milk, it's for your overall health and functioning. So that's one part of the component. Thyroid, oh my goodness, I suffer from thyroid issues. You suffer with thyroid issues. Oh my goodness gracious, the thyroid. And what is normal in labs to one doctor may not be normal to a different doctor, and you may not feel normal. So thyroids is like a big soapbox that I get on also. And a lot of doctors, I hear through my clients and patients that their doctor is like, oh, there's so many hormonal changes after you give birth. We don't want to check your thyroid until your hormones have stabilized more. And that's like at 6 months. They're like, yeah, there's no point to check your thyroid right now. But there's something called postpartum or pregnancy thyroiditis, where the pregnancy or the postpartum period is actually triggering the inflammation of the thyroid and the dysfunction. So the thyroid kind of helps everything function. And once again, even without it helping your milk supply, having your thyroid regulated makes you a happier, healthier person. A lot of, in the past, a lot of mental health issues were attributed to women with thyroid issues that were thyroid issues and not actual mental health issues.
Yeah. Makes a lot of sense.
Yeah.
And touch on PCOS.
So PCOS is basically your testosterone heavy and estrogen light, correct?
Mm-hmm. It can be
a various,
yes. It's kind of a catch-all.
Yeah. So PCOS oftentimes has an insulin resistance factor to it. Like PCOS sometimes can be managed with a diabetic diet. So again, my insulin resistance train.
Mm-hmm.
Okay,
yep.
And it can affect getting pregnant. Thyroid issues can also affect pregnancy. People that have lost weight due to while being on like metformin and stuff like that often get pregnant, like when they're when they thought they couldn't. Mm-hmm. Same thing with PCOS. I have seen mixed results clinically with whether or not milk supply is affected by PCOS. I have seen oversupply in some moms with PCOS that I was shocked. And I'm looking at their breasts also. Like there's a wide-spaced kind of, drawn out to the sides, like nipples pointing, east and west, is kind of a PCOS-looking chest to lactation consultants. And I have seen oversupply with those breasts or undersupply, and nobody has a crystal ball, and we don't know what we're going to get.
All right. I want to talk about how some moms just perceive that they have low supply. I know you see that a lot.
Oh, and it's significantly more present. Like I see it a lot more with the population that I'm seeing in the hospital. People don't understand how breasts work. They don't understand like what we discussed earlier, where like the placenta, the development of the placenta causes the colostrum. The colostrum, nipple stimulation, milk removal makes the colostrum transition into more voluminous milk. So they look at their breasts and they're like, it's not spraying and skirting across the room, something's wrong. Or the perception of crying always being hunger. Always being hunger. If a baby is crying or fussy, that baby's hungry, you don't have enough milk, that baby's not getting fed. And that's like a cultural thing. Also, some cultures and historically have seen colostrum as dirty, or like not clean for the baby or not good enough. They also, that's why there's been such a like health promotion talk about like, oh, your colostrum is liquid gold. It's amazing. It's to counteract some of those, historical beliefs about colostrum. Oftentimes colostrum comes out like clear. And if you think of like cow's milk, a bottle of cow's milk or a bottle of formula that's what milk is. When it comes out clear or golden or it's sticky or it's just in drops, you don't have milk. But the milk is in, you have milk. And there is a higher rate of this within Hispanic cultures. I feel like I want to have a sign put on my scrub top saying "Tu tienes leche," like you have milk. Like colostrum is milk. It's here. Like I just expressed it. It's there, and it's what the baby's body is expecting. Like I've had some moms that have had way too much colostrum production in those early 2 days in the hospital, and the baby is choking and gagging because it's too much, and it's not what the baby's ready for yet, right? So it causes its own issue when it's a larger volume. Babies' stomachs are very small, and they don't need very much. And also, they usually have, depending on the baby and the medical situation, I would say preemies, this does not apply to preemies, but most full-term healthy babies are born with fat deposits to protect them for that first 24 hours while the mom and the baby is figuring out this breastfeeding thing. And the baby's only getting drops. Mm-hmm. And it's okay and it's normal. It's also expected for babies to lose weight after birth, up to 10% within the first 3 days. So it's giving your body and your baby a chance to figure things out. But people flip out if the baby cries, if the baby's fussy, if the baby wants to nurse, cluster feed, which is like feeding very frequently and only taking very short breaks. They are like, oh, I don't have milk. I don't have milk. I don't have a milk. And it's very prevalent. And it's a friend of mine and a former boss, she did her dissertation on perceived low milk supply. And part of that was gathering research from the world globally. And it's a global issue. It is not just like, I was like, oh, it's Americans. Like we have pumps. We're over analyzing things. We're just uptight. Nope. Global. Worldwide, perceived insufficient milk is global.
I can understand because you can't see it going into the baby, so
yes.
You have no idea,
yes.
And it's hard to be trusting.
Yes,
that the baby's getting what it needs.
I think that the more that people experience other people's breastfeeding, and it's more public, and it's more, people are more comfortable out in public breastfeeding, and we see it working, and we trust it. That could shift the perceived low milk supply. Me personally, my mom breastfed me and my siblings, all of us for like 22 months. So I knew breastfeeding could work from that angle. And then I had my best friend before I had my kid. I watched her breastfeed her kids, and I saw it working. And I saw like one of her kids, Moatmean, is just like this big, chunky, fat, yummy baby. And it was all breast milk, man. And so when I had my child, it was shocking that I was like, oh, I just knew that breastfeeding should work. So I'm going to make it work. And it worked. Like, I didn't expect failure. I expected it to work.
So how does a mom know that she's actually producing enough? Is it like the growth chart? Are they, staying on the growth curve?
So the growth curve and all that stuff, like if we put the birth weight and we know that babies are going to lose 7 to 10%, I don't feel like the growth charts allow for that effect. It's just like birth weight, keep going on the same angle, right? And it's really like, woo, and maybe like you're never going to get to the line of the birth. again, especially if it was a medicalized birth that had a lot of IV fluids, because I've worked with babies that are birth center where there was no IV fluids at all, completely natural vaginal, no, limited medical interventions, and home birth families. Those babies pee and poop like once the first 24 hours. Hospital babies that have had medicalized births with IV fluids, they pee and poop a lot. So there's, and if they're peeing and pooping that much, some of that isn't from feeding. And even babies that aren't feeding great are still peeing and pooping a lot in that first day. And I'm like, this is from, losing the water, the fluids from the birth that was overly plumped up. Mm-hmm. Yeah. I have a picture of Jax right after being born via C-section, and Jax looks so bloated and like not normal. I'm just like, oh, yeah, you were like plumper than you should have been,
Mm-hmm. You're going to expect a dip in that first little bit. But further out, because we've both seen these moms further out that are still worried that they're not producing enough, and they've got these little round babies.
Chunky babies. So we want to be meeting developmental milestones. We want to be averaging over time an adequate amount of weight gain for the growth chart, okay? But there's also babies that are 0% babies or less than 0% babies on the growth chart, and babies that are over 100% on the growth chart, that they're not on it, right? Mm-hmm. There's like the bell curve, there's outliers. So basically, if your baby is peeing and pooping well, 4 to 6 wet diapers, pooping regularly, and that's dependent on age. It varies by age, what we're expecting babies to poop, and feeding method. I like weight gain over time more so than the growth chart, to be honest, and then also development. Like if a baby is having issues with development due to their weight gain, that needs an immediate intervention. If a baby is having slower than average weight gain and the developmental signs are all good, it's a happy baby, the baby's, the pees and poops are good, then I feel like that buys me time when I'm working with a dyad to figure out what's going on. And then also, I feel like with some dyads that I'm working with, I'm monitoring them very closely. And when you monitor these babies very closely, they have plateaus. Mm-hmm. And so sometimes we catch a plateau and everybody freaks out. And babies, by the way, they eat a lot, they gain weight, they slim out, they get longer. They eat a lot, they gain weight, they slim out, they get longer. And during the slim out, get longer phase, before, after, or during, sometimes they don't eat as much. And that's normal too. And babies don't gain weight like this, they gain weight like that. So there's the Netflix documentary, Babies.
Yes, they researched that.
Yes. And it's legit. It's not just like I saw this on Netflix and there's no research to support it. No, this is there's legitimate research. And yes, I did hear about it from a Netflix documentary. But it's accurate. They said that babies can grow an entire inch in 24 hours. So if the baby's body is focused on growing an entire inch in 24 hours, they probably aren't gaining weight then. Like all of the energy stores are to producing more bones and more baby. Yeah. And so it's just, to be I wish weight is not the only factor of a healthy baby. It is one of many factors. And so looking at the whole picture before flipping out and jumping the gun to formula or stopping breastfeeding or whatever happens, or just being miserable because you think your baby's starving. There's so many different things. And looking at the whole picture is what really helps me give the best clinical advice.
We've talked about the different causes of low milk supply on the mom side. Mm-hmm. Let's talk about how the baby might be a cause of low milk supply.
Yes. When baby is coming to the breast and is not adequately stimulating or removing and transferring milk, it can cause low milk supply to develop. So sometimes babies that have, funky oral anatomy, they have a lip or a tongue tie, and they're never really draining the breast or transferring at the breast effectively, that over time can just make milk supply plummet. Or babies that have very low tone, sometimes they're not suckling and stimulating as aggressively, and they're kind of catching whatever kind of falls in their mouth instead of actually stimulating properly and having that nipple pulling and that stimulation with the milk removal. And then over time, milk supply plummets.
Yeah, I've seen that quite a bit with the moms that I have treated over the years. Automatically want to check what baby's doing, and there can be, lots of different restrictions throughout the whole body.
Torticollis.
Some of it can be the neck being stuck from the way they were positioned in the uterus. There can be restrictions within the pelvis, within the whole trunk, in the shoulders. I see so many kids who they barely have a neck showing at all. Their fists are so close to their mouths that they can't open adequately, or they're stuck in extension and they can't open adequately, just trying to open versus getting their head here, and they can all of a sudden open to be able to latch on properly, or the shoulders come down and they're able to open, and their hands are out of the way, and they're not just rigid, because it's much, much harder to drink anything when they're rigid versus when they're relaxed and able to be belly to belly with mom. And I, with a lot of these kids, I'll see the mom because she has mastitis, and it's like the baby seems to drink really well on the left, but I keep getting mastitis on the right, and it's usually an issue with the baby at that point.
And most moms think it's their breasts that are the problem. Like
they automatically
blame ourselves.
The blame, yes.
We blame ourselves. We blame ourselves for all the things all the time.
Yeah. Or it's just the right breast won't, it just won't produce enough.
Well, the nipple's not shaped right. The breast isn't shaped right. Yeah. I'm holding the baby wrong on that side.
Yeah. But a lot of times it's the baby that actually needs the treatment.
Yeah. The amount of babies stuck in their shoulders that I see, that I just simply grab and hold the baby's head in a certain way and kind of let the baby just kind of move. And they're like this. They're like, their baby's always like this. And then just kind of let's get this neck. And I'm not skilled in what you do, but I've worked with you a bunch, and I've seen some of your tricks and techniques, and I'm just doing little things like just holding the head off of the shoulders. Just putting my fingers in between, right here. Mm-hmm. That's all I'm doing. And all of a sudden the baby's like, I can open.
Yes. So not pulling, not pushing, not stretching.
Simply holding.
Just holding.
Yeah. And letting that baby kind of wiggle itself out. I think that also people, so in the hospital again, there is this push of support the head. Support the head. If you don't support the head, the thing's going to roll off. It's going to go into the next room. Baby's going to die, right? Very extreme. Oh my God, you have to support this head. But supporting the neck and the upper shoulders supports the head. And that's another mission along with insulin resistance in my hospital job. I'm but we can support the neck and the shoulders. And then the head is supported. Because sometimes babies at the breast, the instinct is to push the head or to hold the head because they're deathly afraid that something bad's going to happen if that baby's head moves the wrong way. And it's just allowing them to know that, look, you can't, you're going to go. And babies also, when they get the pressure on the back of their head, there's a reflux that helps them get out of you through the vaginal canal. They feel pressure on their head and they move. Have you ever heard a mom say, oh, my baby fights me at the breast? It's usually because they have a finger clamped onto that head. And I'm like, support the neck and the shoulders, not the head.
All right. So if If a mom needed to increase her milk supply,
Yes.
what are the tricks?
The very, very first thing, nipple stimulation, milk removal, frequency. If that's not happening, we don't go down the rabbit hole looking for more. So once that is happening, and what that means is nipple stimulation, milk removal, so either a pump or a breastfeeding that is transferring effectively, so baby doing their job effectively, or the pump doing its job effectively without causing pain or damage frequently. So like 8 to 14 times in 24 hours, some days. So it's like we have this every 3 hour, 8 times a day medical model of feeding. And that's not how babies eat. Sometimes they'll cluster for 4 hours and then maybe they'll take a little nap and then it changes. And so enough nipple stimulation and milk removal that's effective for that dyad is what's important, and at least a minimum of 8 times a day. Sometimes I have moms come to me, they breastfeed once a day, they're pumping 4 times a day. And they want to know what herb they can take or what they can eat, or is there a medicine, or is the electrolyte powder, are they not drinking enough water? And I'm like, we have to first start with nipple stimulation, milk removal, effective milk removal, frequency, because otherwise there's not going to be milk. Another thing is late at night between 1 and 3 a.m., that's when your prolactin's the highest. And if your prolactin gets stimulated, it helps your milk supply. And a lot of moms, when they return back to work around 3 months, need sleep. And they choose to sleep the midnight to 5 a.m. stretch, which kind of nixes that wake up. And sometimes that's the cause of their milk supply plummeting also, is that they're like the timing of when they should be getting at least one stimulation and milk removal in isn't happening at the right time. So that's one piece of like what moms can do is like instead of sleeping from midnight to 5, maybe sleep from like 8 to 1, and you're still getting the same amount of sleep, but you're waking up to get that breast stimulation in the middle of the night. Herbs, yes, they work. I like referring to herbalists. I will say that depending on the way that the herbalist practices, it can be very overwhelming for postpartum moms. And I love herbalists, and I'm not saying anything bad about what you guys are recommending, but these moms are already stressed, exhausted, and are having difficulty, and then they get bags of teas or soups to make, and nobody's making it for them. So like in, Chinese culture, there's like family coming over that are making you these teas and soups and concoctions to help nourish your blood and your qi and all that stuff. And then that does really help. But I would say if you are a mom and you do not have a support system and you're not going to make the teas and you're not going to make the soups, get a capsule. Take a pill. And you may not need to see an herbalist because they might recommend all of these other things that might be really overwhelming in addition to everything you're doing without adequate support. So also there's medications, and those medications both have significant side effects and risks. One of the medications is not legal to be prescribed for increasing milk supply in the United States, and it's called domperidone. And I think the reason the FDA doesn't like it in America is because of it can affect heart issues. It can cause heart issues. Sometimes people get that illegally, and I have had many clients do that, and I'm always terrified. And I'm like, please be in the care of a doctor just in case something happens, even though you're getting it illegally, and tell them that you're taking something that you got over the internet. Please, please, please do. I've had clients have severe side effects from domperidone and not be in the care of a provider. And I go to the ER, and the ER docs are like, "Oh," and they don't tell because it's illegal. The drug's not illegal, but for that purpose, it's illegal. The other one is Reglan, is a dopamine antagonist, and it can cause postpartum depression in moms that don't have risk factors for that. And arguably, having milk supply issues or feeding issues is also a contributing factor to postpartum mental health issues. And adding that medicine on top of it sometimes really backfires. However, I have seen dyads where the mom takes the medication, it increases her milk supply, and the joy and the happiness from being able to fully feed her baby counteracts the negative effects of the meds. So, if that's usually not in a family in a mom that has previous significant mental health history. It's usually in a pretty healthy, no history of mental health issues, and then this one thing is really upsetting them about their postpartum experience. That changes, and it balances each other out.
On the topic of domperidone,
Yes.
And you had mentioned that people, have nasty side effects, end up in the ER, and don't want to say anything. Yes. I will add in, as someone who is married to an ER doc, the docs don't care.
No.
They don't.
No.
So please just tell them so they know what
they're dealing
with. They're not going to report you to anybody. They just want to help you.
Yeah.
So, if it's something that you've taken, please be upfront with the physicians and tell them what you have taken so they know how to treat you.
And honestly, even illegal substances.
Yes. They're not going to report you. They just want to treat you.
They just want you to be better.
Yes.
And healthy.
Yes.
Yeah.
And it helps them tremendously to know how to treat you.
Yes.
Yes, if you've taken something, just be upfront so they know how to help you.
Yeah. If your goal is to breastfeed and you have a difficult birth, accept the help and support and the insistence of lactation professionals to get you to have frequent nipple stimulation and milk removal. And start there before looking and going down various and sundry rabbit holes that could affect your health. And it could actually, sometimes there's some herbs and medications that can actually make you have less milk. Find out if you truly do have low milk supply, if you think you do, before jumping down that rabbit hole. Just get help. Mm-hmm. Get help from somebody that has experience and can guide you through the process. I have a job for a reason. If this was all easy and natural, I wouldn't have a private practice and I wouldn't have a job. So it's not easy and natural because I'm here. I exist.
Yes. So I think in a nutshell, if you are thinking that you have issues with low milk supply, no matter where you are in that kind of continuum of feeding your child, please see an internationally board certified lactation consultant and get some help that way. I hope you enjoyed this episode, and we will see you next time on the Postpartum Years. Thank you.